Right, so Roger, we have known each other for a few years now. We've been working together on various things like your social media Twitter project in education, and I know you do a lot of work in evidence-based practice, but we've never really spoken much about your work to do with the cervical spine. So I was wondering if we could have a little chat to you about that today.
Of
Um,
course.
Excellent. So perhaps you could start by just letting all our listeners know a little bit about you and what you do for your work, so that they can have an understanding of where you're coming from.
Absolutely. So, hello, everybody. So, my name is Roger Kerry. I work at the University of Nottingham in the UK. I'm a physiotherapist. And as Rachel said, I've got a number of interests in different areas. Well, on the clinical side, myself and a colleague, Alan Taylor, have been working for the last decade or so looking at risk assessment procedures for cervical spine assessment and management. And I suppose that's where we come in today.
So first of all, I see. So in our Learn topic this month, there's a couple of chapters that you've written in Nikki Petty's Neuromusculoskeletal Examination and Assessment book on the cervical spine. So to write those chapters, you must be quite an expert at assessing cervical spine. So I was wondering if you might be able to make comment on what would you consider to be the most important things to remember when people are assessing cervical spines?
Well, as I'm not comfortable with the word or the term expert at all,
Okay.
especially applied to me, but I think it's just important to think of what we know about the body and movement and the evidence. And when we're looking at painful conditions and patients experiencing painful, uncomfortable episodes, we know more from the scientific study these days than we have before. And all that does is allow us to focus on what's really important and what's necessary, what's meaningful. And a lot of this boils down to functional movement and not necessarily normal movement in some sort of textbook. And I think over the years, and if you look at clinical practice, what happens is a lot of time is spent doing things we don't really need to do, and we're not getting that much meaningful information from. And you can just look at somebody spending half an hour with a patient, and half of that really is unnecessary when you look at the evidence we've got to tell us what is given as clinically useful information, what's not. So I like the idea of really continually thinking about what we do in assessment, and as a starting point, having that question: do I really need to do this? What information is it giving me? Where's it going to lead me? How is it relating to this clinical hypothesis we've got? So this is just a really normal way of thinking for most people, and it's blending our clinical reasoning skills with the evidence base and really thinking and questioning what we do. So, that's at the top and bottom of it all, really.
So what you're kind of saying is picking out the sort of functional and sort of aspects of the assessment that really are working towards proving or disproving any clinical hypothesis you have going into the assessment, as opposed to working through a list of techniques to perform.
Yeah, you can frame it that way quite easily, and that's a nice, clear way to frame it. Well, one of the problems with teaching and learning, when we learn something like assessment of the cervical spine, one of the best ways to teach that is to go through procedures and ways of doing things and patterns of doing things, and then that's very difficult to move away from. But there comes a time when the evidence becomes overwhelming to say, well, come on, you really don't need to be doing this, you don't need to do that, but you need to be doing more of this, that, and that for this subgroup of patients, and a bit more of this, that, and that for this subgroup of patients. And then it is important to have that flexibility. Now, the key word you said there was function, and I think again, looking at studies of practice and observing clinical practice, I think function is not properly attended to in the cervical spine, again, in any sort of real world meaningful sense. I think you see a lot of lip service paid to function of the cervical spine, but what do we really mean when we talk about function? And if you can focus an assessment around function, the picture becomes very different, and that guides you very much to what you really need to do and not do.
Yeah, so that's I guess that's really interesting to hear you talk about assessment like that now, because I guess when I came out as a new clinician, you're still expected. I felt like I was still expected to work through that list of techniques, but what you're saying now is that perhaps even as newly qualified clinicians, we should be able to pick out subgroups of patients and what's important to those patients and tailor the assessment to that for each individual patient. Is that right?
Yeah, absolutely. And I don't think there's any reason not to be taught as an undergraduate, let alone postgraduate study or professional development while you're working. But I don't think there's any reason not to be learning as undergraduates about turning around the whole approach to how we understand pain, first of all, and in this example, painful episodes with people with neck and head problems, and thinking not so much about, okay, here's an approach I was taught to assess a patient, but think about, right, what subgroup of the population does my patient fall into? What's the evidence that supports the meaningful things about that? How does that translate to assessment? And so we're approaching the problem from completely the other side. And actually, the techniques we do are really secondary to the reasoning and the evidence. And I think we've got a tradition of being taught techniques, now go and do them, and then work out what happens, which is not a healthy thing to do then.
So that's a really interesting approach to assessment that I haven't really spoken to anyone about before. I think I always assumed that was something that you learned as you became more experienced, but to be able to do that earlier on in a career is a really valuable thing to be able to do.
Yeah, and I just don't see any reason why that has it. I think the likes of you and I haven't been around for a few years and gone through a sort of traditional education. So it's often difficult to see, or not difficult to see, but you think, oh, well, that must be really complicated because it's taken me years to sort of think like this. Mm. But actually, to a fresh undergraduate, it doesn't make any difference whether you teach them this way or that way. We just need to position ourselves now to say, well, actually, here's the evidence, here's some logic and reasoning and thought and experience. Let's put it all together and sort of change the way we think.
Yeah. So it's a lot to do as well, isn't it, with integrating or making sure that you're using your good clinical reasoning skills and being skilled in clinical reasoning as well, which I know is another one of your favourite topics.
Well, yeah, absolutely it is. And there's a lot of talk these days, i.e. 2014, about how clinical reasoning and evidence-based practice sit together. And I think we need to carry on having that conversation because it's going to be quite easy to almost downplay the role of clinical reasoning, which brings in our experiential knowledge and our experience and our logic. And it is at one level feasible to say, well, actually, you don't need all that because all you need to do is look at this data and this works best for this group of people. That's what, just do that. But of course, as well as anybody else, that's not how the world works. And we need to find a way in our reasoning models to integrate the best of the evidence and let all of that influence the way we approach clinical problems. And I think probably some clinical reasoning models need attention to now to allow for a better integration of published evidence into them, whilst at the same time not dismissing the other valuable parts of clinical practice, which you do see is happening.
Yeah, so it's all comes together with clinical reasoning. So with our assessment skills and clinical reasoning skills, and using the evidence base that's available to us as well.
Yeah, and if we can teach ways to do that for our undergraduates, that's, that we're starting to get somewhere towards how the future might look. And like anything else, it's easy to take the extremes of the thing of the world and think, well, it's all about evidence, it's all about evidence-based practice. Well, that is of course, that's a firm part of the world of clinical practice, but it's not all about that. So when you hear students going out into placements and almost quite arrogantly saying things like, well, where's the evidence for that? Well, that's an unsettling thing to hear. Of course, we want to know where the evidence is, and we want to know where the gaps in the evidence are, but it's an extreme approach to helping patients, and there's so many other facets of humanity that we need within there as well, and that's where a good clinical reasoning model should come in.
And I guess it's all geared down to doing individualised management for each patient as well, isn't it? Instead of putting a formula on each patient in their management.
Yeah, and again, that's really interesting. We've mentioned subgrouping of patients earlier, and research into subgrouping populations, and again, in this case, neck pain is getting better, and we're now better able to identify subgroups of, say, whiplash patients better than we were 5 years ago, and that's great. But there's a really interesting paradox with subgrouping as well, because if you carried on with the logic of subgrouping patients, it carries on until the subgroup is n of 1, and you're talking about an individual patient with individual characteristics, and we should tailor assessment and intervention to that person. So the data can really help us identify groups, but still within that, there's going to be individual needs and characteristics that influence our assessment.
Yeah. Okay, well, I think that's a really nice roundup of how to approach assessment, and I guess that goes not just for cervical spine, but for all assessment as well. So using your knowledge, using your clinical reasoning skills, looking at the evidence base, and looking at subgroupings of patients, and then also managing to tailor all of that into an individualised approach for your patient. So that's quite a nice, I think I've probably hopefully summed that up, what we've just talked about there, quite nicely.
Absolutely.
But so perhaps we could move on to you and your work which you've done a lot of your work with Alan Taylor, which you mentioned earlier, in the cervical arterial dysfunction. You've just written an amazing page on Physiopedia on the CAD sort of model, and you describe it on your page here as a model that is used to identify underlying vascular pathologies masquerading as neuromusculoskeletal pain, and to identify the risk of developing arterial pathology during assessment or intervention. And now I know that you've done a lot of work on this, and also in relation to the new international framework for examination of the cervical region for IFOMT. So I was just wondering if you could perhaps just talk a little bit about your work on cervical arterial dysfunction, and then the rationale moving into the framework that you developed with a whole bunch of other experts from around the world.
Yeah, sure. So I suppose the beginning of this was, well, myself and Alan Taylor approached this from an unusual perspective, I suppose, because now when you look back at the CAD framework and everything, it relates itself very well and very fluently to the model that it's superseding, which is the idea of VBI, vertebrobasilar insufficiency, and pre-manipulative testing. So when you look back, you can see how it relates to that now. But actually, 10, 12 years ago, when we started thinking about this, we came at it from a slightly different direction, because we were interested in patients with vascular problems per se in their lower limb and thereon. So Alan's original work was with professional cyclists with exercise-induced leg pain, and looking at subgroups of those people who had vascular problems. So we were very tuned in to understanding blood flow issues in the legs and the arms and the torso. And a natural extension of that was thinking about subgroups of patients who had blood flow problems to their head, not necessarily as manual therapists, but just as people interested in healthcare. And so we started to look at ways of assessing those people and the ways that medics were assessing people with vascular flow problems in their neck and head, and piecing together systems and ways of thinking about that. And then that sort of got integrated into the whole manipulation debate, which is a non-debate as far as I'm concerned. But I think that caused a lot of confusion, both with us and with other people. And what we're trying to do now is sort of clarify where we are and clarify that confusion, and actually say, the whole thing doesn't need to be confusing. This is really simple. It's not a clever model like Peter O'Sullivan's back pain systems or anything like that. This is really simple stuff because we're both fairly simple. And we just try to develop a way for therapists, whether they're manual therapists, physiotherapists, whatever, to, again, identify the correct subgroup of the patient and do the right assessment and management for them. It's simple as that at the end of the day.
And so this, from the CAD model that you've put forward, what is the simple message from that for practicing physiotherapists to take away?
Well, at the most fundamental level, it's a matter of, okay, I'm a physiotherapist and I see patients, and patients come to me with head and neck pain. And there's a whole bunch of reasons why somebody would have head and neck pain. Very commonly, it's due to the dysfunction of the musculoskeletal system and somebody's response to pain and the way their brain's interpreting their sensory input and influencing motor output and all that. So that's a very common type of head and neck pain. But there are other causes of head and neck pain as well, like cancer, infection, whatever. And also, a cause of head and neck pain can be a vascular one. So there's something wrong with the vascular tissue and the blood flow to the brain. So it's simply another cause of head and neck pain. So when we're seeing a patient and we're generating our hypotheses, it could be that is one hypothesis, which you would then test by the appropriate questioning in your examination. And it's those sorts of questions we've tried to highlight in the CAD framework. So if you think about this, it's a very different way to understanding a patient from the VBI pre-manip model, where we would say, I've got a patient with head and neck pain, I want to manipulate them, I'll just check, first of all, if they're going to have a stroke or not. Well, that's a largely uninformative, not very useful way to think. So, again, it's just basic clinical reasoning, basic pattern recognition, generating appropriate hypotheses, asking the right questions, perhaps doing the right physical examination, and making a sound clinical decision based on all of that data.
So really, CAD is a subgroup of patients who your patient could present with symptoms that lead you to think that they may well be in this subgroup, and it's a hypothesis that you either need to prove or disprove. Instead of just being a test that you do, a pre-manipulative test that you do, basically.
Absolutely.
Yeah.
Absolutely.
And so, do you use this framework in anticipation of performing manual therapy techniques, or does that become more? Should you move more on to looking at the IFOMP framework that has been published recently?
Well, the two things are very similar now, because the IFOMP framework is very reflective of the work that Alan and myself have done. So the basic reasoning within the IFOMP framework is the same as what we've just been talking about there.
Yeah.
In relation to manual therapy and doing manual therapy, that issue sort of sorts itself out, because what we're trying to do here is identify patients with potential vascular pathology, a CAD thing, or a predisposition to CAD. And then with those patients, we wouldn't really want to be doing any manual therapy techniques that compromise the vascular tissues anyway, if it's a patient with a predisposition. And if it was a patient presenting with an actual pathology, which means impending stroke, then we're going to refer those patients on anyway. So the issue of your manual therapy causing a stroke becomes less and less of an issue, because you've ended up with a subgroup of patients who aren't at risk of arterial dysfunction as far as we know from the evidence. Of course, there's going to be stray ones in there with some bizarre spontaneous issues, but by and large, you've segregated your patients to such an extent that the ones that haven't got CAD, you're fairly happy with doing whatever we want to it. And we know from the blood flow studies now that a lot of the techniques that we do, like some of the manipulation techniques, don't really have an effect on the blood flow in the way that we thought they would just a few years ago. So the issue of techniques being dangerous is not really an issue, because we should say, well, dangerous to who? Yeah, if you was doing that on that guy with impending stroke, it is dangerous.
Yeah.
If you're doing it to these people, which are the vast part of the population, there is no real danger clinically, epidemiologically, scientifically. There doesn't appear to be. So that issue of, the CAD framework relates to manual therapy very well, I think, from that perspective. But it's not a matter of the old way of doing things where we do a test before we do a minute to see if there's got to be a problem. We know that model doesn't work empirically.
Sure. So it's kind of removing removing that subgroup of patients who do have CAD from possible risk from orthopedic manual therapy intervention.
Yes.
And what I should point out is in the IFOMP framework here that orthopedic manual therapy interventions includes manipulation, mobilization, and exercise.
Yes, and and we'd even add to that, although we haven't stated it in the framework, even parts of the assessment.
Yeah.
Because the issue is, if we think about the risk subgroup now, the people with a CAD pathology, so for example, one of those pathologies might be something like a very fragile atherosclerotic pathology in the carotid artery, where there's some emboli just about to blow and give a major stroke. Now, we know from some blood flow studies that extension of the neck influences the hemodynamics in the carotid artery. Now, so if I got that patient who sat in that very risky subgroup, and I got them sat on the end of the bed and I got them to look up to the ceiling during assessment, that's a risky procedure. So
sure.
The idea of expanding the range of movements, manipulation movements, mobilization movements, assessment movements, exercise, is to think about the nature of the movement itself and how that relates to the blood flow in a particular vessel, like that example there.
So a lot of the assessment for this subgroup of patients should indicate that it might come from clear subjective questioning.
Yes, yeah.
So in your initial patient report and when you're questioning them when they first come in, before you do any physical techniques or assessment with them. Again,
So within the framework, we try to give some sort of guidance towards that. So again, we try to identify a particular pathological pattern.
Yeah.
And we have detail from clinical scientist studies that. So use the example of the carotid artery again. A pathology in the carotid artery tends to present with pain in a certain distribution around the head and neck of a certain nature, so you'll try to pick up on those clues. There'll be a predisposition of the patient to have that pathology, which is related to their cardiovascular risk, so we want to ask questions about their predisposition. nature of the pain, the onset of the pain. We know certain types of mechanical forces affect vessels in certain ways, so we can map that onto it as well. And the way the pain's behaving since it's been on can be characteristic of a vascular problem rather than a neuromusculoskeletal problem. So all that, of course, should be identified in the history taking.
Yeah.
And you're planning for the physical examination. It's got to be influenced by that. And if you're scoring a lot of points on that in the history taking, and you think, crappy, yeah, this guy here fits into this CAD thing. He's got this drooping eyelid. He's got these things going on. There's a very characteristic of a serious neurovascular event about to happen. The last thing you're going to do then is get that guy and do your normal physiotherapy assessment, looking at his range of movement and stuff, because that's not the subgroup of patient he's in. Now, there are other types of physical examination we can do for CAD, but they should be the icing on the cake, really. The bulk of the reasoning and decision making should be made in the history taking.
And I think that you've just brought it back round really nicely to where we started in cervical assessment. You are looking to take the history and subgroup patients and use your clinical reasoning and the evidence to make that assessment specific to the patient.
Absolutely. So it's a perfect example of what we started with.
Yeah. So just tell me, where does, in relation to a recent article that you published in Manual Therapy, the Manual Therapy Journal, where does taking blood pressure fit into all of this?
Well, so this has caused some controversy. I mean, essentially, there's two broad reasons for including blood pressure measurements in these patients. One is that we know empirically from very robust, very large-scale epidemiology studies that hypertension is the primary risk factor for the sorts of pathologies that we're talking about under the CAD umbrella. So if we're trying to profile our patients to see what their risk of predisposition is, then understanding their hypertensive state is just one piece of potentially important information. You know, it's not diagnostic. It's not diagnostic information with some sort of sensitivity and specificity test, but it forms part of your reasoning and profiling of risk for the patient. So that's one reason for taking it. But the other reason for understanding a patient's blood pressure is that in some of the pathologies under the CAD umbrella, and a fairly acute, subacute dissection event or something, in a proportion of those patients, there's a dramatic systemic blood pressure response. So then it can be almost diagnostic. So if we've got a 32-year-old guy who's had a recent car accident and he's got this pain characteristic of an arterial dysfunction and blah, 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 and you take his blood pressure and it's something like 220/180, well, that's informative information that can help you understand the nature of the problem, and also strategically help you refer that patient on for medical referral with that sort of information. So the problem with this is that consistent data is lacking because of the size of the subgroup and because of the inconsistencies in reporting. But what we've tried to do over the last decade is mop the best of the information up and see what data says from medical sciences, from medical practice, from clinical practice elsewhere. And this would seem like the most sensible approach to take. And we're not stating that it should be doing, but we're stating that it's a very logical and evidence-based inclusion into our identification of CAD patients, basically.
So it wouldn't be a standard assessment procedure that we'd use, but it would perhaps be one of the pieces of our toolkit that we would get out if we suspect that we have a patient that's fitting into this cervical arterial dysfunction subgroup of patients.
Absolutely, that's all this is. We recognise that pattern in the history. We might want to test for a further piece of information, and that's one tool we could use if it's indicated by the history taken, and if you think this patient is fitting in the CAD hypothesis. So again, there's big misconception about the framework and things like that about iFont and we're not saying for a moment that all physiotherapists should always take blood pressure for all patients. That's not the case at all. We're saying, it can be a tool to use in your profiling or identification of a pathology in a certain subgroup of patients.
Excellent. I think that makes sense. It totally makes sense. We're certainly in a good position to be able to do this, take blood pressure, and but it's not one of our original key skills, and we should use it. We should use it appropriately instead of just adding it onto the long list of things that we do in our long list of assessment techniques. So again, just one of the things in the toolkit that we should get out when we use our clinical reasoning skills to make the right decisions of how to assess a patient, I suppose.
That's correct.
Yeah. Okay, that's great. I think just to, that's all I really wanted to chat to you about today. So I just wonder if, I don't want to keep you for too long, so I was just wondering if perhaps you have just a sort of summing up message on either on everything we've discussed or just on the CAD sort of message that you want to put across to people that might be listening that they can take into their practice.
Yes, well, I think it would be useful if people did go to the effort to. There's a recent publication in manual therapy by the working group that's published the IFOMT guidelines, and it's a shorter paper, so it should be more readable for people. That's just been published. But what is really interesting, we got an excellent response to that paper by some clinicians over in Belgium that highlighted a few issues, some of which we've talked about today and some other ones. And we were given the chance by manual therapy to respond to that response. So, and I think that trail of conversation is actually really informative. It wasn't planned; it's just naturally emerged from the sort of academic system, but it's led to a very fluent, very nice conversation that I think clarifies some issues there. So that would be really useful if people wanted to read through that. And that is on the articles in press section in the manual therapy website if people want to look at that.
Okay, well I wasn't actually aware of that. So what we can do is we can try and see if we can make those available to our members and so the people that are listening to this. So we can certainly put some links up, and if we can make them available, we certainly will.
Great.
So thank you for talking to us today, Roger. It's been really great to talk to you. I think that's been really useful, definitely very interesting and very useful for people to take forward into their practice and giving people a lot to think about. So thank you very much.
Thank you very much for inviting me to your podcast, Rachel. That's great.
You're welcome.